right, class, we are now on part 2 of the respiratory system. With part 2, the main topics we'll be discussing is airflow resistance. We'll look at how diffusion occurs at the lungs, and then partial pressure of gases. So first, we want to understand airflow resistance. So as with blood flow, resistance to flow and pressure differences between two areas affect how much airflow can get into a specific area. We want to look at that relationship, and we see that it's expressed by airflow equals P1 minus P2 divided by resistance. So here we've defined each one. So P1 minus P2 is mainly just talking about the pressure difference between two areas. We'll give an explanation or an example of that. And then resistance to flow between two areas is just talking about opposition to flow. So we know that air flows from a high area of pressure to an area of lower pressure. So an example of that would be air flowing between the atmosphere into the lungs during inspiration. Or when we look at pressure difference between two areas, that could also be between two ends of an airway, so like the trachea. So between those two ends, what is the pressure difference? And then next with resistance, so resistance to airflow, that's opposition to flow. So how much air is actually getting into a certain region. We can look here and talk about how does airflow increase. So we already talked about what determines airflow, and now if we amplify the pressure difference between two areas, we'll have greater flow. We talked about this with the cardiovascular system. We talked about how amplifying the pressure difference between two chambers or between two ends of a vessel will have an increase in blood flow. Same thing with airflow. When we amplify the pressure, we're increasing one more than the other, or one area's pressure. And when we have a greater difference between the two areas, we're more likely to have an increased flow. And then also decrease in resistance. So this one makes sense, just like with blood flow. If there's a resistance, if there's a blockage, we're not going to get as much blood flow to a specific organ or tissue. Same with airflow. If there's a specific, or if there's a blockage, let's say in our trachea, or if we have any type of constriction, we're going to have decreased flow there because of that increase in resistance. Let's talk about rest versus exercise here. So at rest, the airway diameter is the #1 determinant of how much airflow we actually get. So diameter of the airway will affect airflow the most. If diameter of that airway decreases by half, the resistance has been shown to increase by 16 times. And then during exercise, what's the main determinant of airflow? It's sympathetic stimulation. So this is talking about hormones, epinephrine and norepinephrine. So our adrenal hormones, or adrenaline basically. This causes bronchodilation. So dilation would expand the airway. So this decreases resistance to the flow, allowing optimal air to be ventilated. Pulmonary ventilation will increase by up to 20 times when you start to breathe through your mouth, not your nose, due to the greater diameter. Usually during exercise, I always learned, y'all probably did too, is that when you run, you want to start breathing through your nose and exhale out your mouth. So that's very energetically efficient, we'll say. So we're breathing through our nose, we're exhaling out of our mouth. But think about during heavy exercise. That's impossible to breathe through our nose. That passageway is so small. So when we start breathing through our mouth, especially with really heavy exercise, we can increase ventilation by 20 times. We can get 20 times more air than we could if we were just breathing through our nose. So let's go over some more terms now in regards to pulmonary ventilation. So tidal volume is abbreviated VT, and what this is amount of air moved per breath. So think about just taking a deep breath. That's tidal volume. That's how much air that you inhaled at once. So per breath, that's tidal volume. Pulmonary ventilation is similar. It's still referring to breathing, but it's the amount of air moved in and out of the lungs in a given time period, usually calculated in 1 minute. So in 1 minute, let's say, what is your tidal volume and how many breaths are you getting in 1 minute? And here's our equation for pulmonary ventilation. So pulmonary ventilation, you can always refer to that as VE, and then we have tidal volume, and then we have frequency. So we know VE, volume of air expired per minute. We want to solve for that. So we have tidal volume times frequency. So an average tidal volume at rest is about 0.6 liters per minute. Maximal exercise, that's going to increase up to about 2.7 to 3.1 liters per minute. So there's our tidal volume numbers. And let's look at frequency. So frequency of breathing, this is talking about how many breaths you take per minute. At rest, it's usually about 12. And then when we start exercising, that increases to 20. If we exercise harder, maybe up to 30. Maximal exercise up to around 40 breaths per minute. So that's how you would solve, or one way to solve for pulmonary ventilation. Another equation is looking at anatomical dead space times alveolar ventilation. So I have our kind of definitions here as well. So we already know VE is pulmonary ventilation. VD is anatomical dead space. And the definition of this is air that never reaches the alveoli to participate in gas exchange. It's the air that we breathe in, but it gets trapped in our nasal cavity, our larynx, our trachea, and our bronchi. So it's the air that does not participate in gas exchange. Where alveolar ventilation is the air that does reach the alveoli and it does participate in gas exchange. So due to the tremendous surface area available for gas exchange, it's not always necessary to use all the air that we breathe in. So when you take a deep breath, not all that air will reach the alveoli. Some of it will get stuck in the respiratory tract. And so when you multiply what does not and what does reach the alveoli, that gives you how much air you actually were breathing in. So this here shows tidal volume. It breaks down tidal volume with one single breath. So we see this orange part, that's the alveolar air. So that's all the air that did participate in gas exchange. We have our anatomical dead space and physiological dead space. They're very similar. They're just kind of referring to the air that does not participate in gas exchange. Let's talk about our lungs and different portions of our lungs. So we have a basal portion of our lungs, which actually receives most of the ventilation at rest. So the basal portion is the bottom. So it's referring to the bottom part. We see that as our bronchi branch extensively, we see that it doesn't just branch at the top, it also branches towards the bottom. So here, when we look at the lungs, this is the basal portion. So at rest, we actually use the bottom portion of our lungs more. The apical portion of the lungs, or the top portion of the lungs, receives increased ventilation during exercise. So when we start exercising, that's when we actually start using our entire lungs, or we start activating more of the alveoli in the top portion. All right, so let's give some typical mean values for pulmonary ventilation. So what we see here, first we have an average person. This person is 70 kilograms, so about 154 pounds, so male. We have typical values for an untrained young adult versus a highly trained endurance athlete. So these are our resting values. So we said VE, pulmonary ventilation, is roughly 8 liters per minute. We said tidal volume is about 0.6 liters, and then frequency is about 12. As you move up, so as we start exercising, we see that these values start to increase all the way up to maximal exercise. So this would be just for the average person. Over here, we see an endurance athlete. Our endurance athlete values you see are very high. I won't say almost double, but they are a lot higher than just our typical person. We'll talk about some adaptations that occur to the respiratory system that contribute to why those values are so much higher. So we'll kind of discuss that as we get towards the end of this whole chapter. One more thing is, how are these values determined? So how do we figure out what all of these values are? There's a device called, or kind of a measurement called spirometry. So spirometry measures how much air inhaled and exhaled and how quickly you can do that. So that's a good test for someone who does have a respiratory disease like asthma or COPD. But you can also do this in athletes to figure out if their ventilation is optimal for performance. Oh, there it is. So lung capacity is determined by spirometry. So I just mentioned that. So like I said, spirometry just measures how much air you're able to inhale and exhale. Let's talk about another term called residual volume. So residual volume, air left in the lungs after a maximal exhalation. So basically inhale, take a deep breath, and then exhale, push everything out. There's still some air left in your lungs. That's residual. Residual just means left over. So normally I would turn it over to y'all and I say, what is the benefit of this residual volume? What this means is, it means that the lungs do not completely empty or collapse. So there's still air in there, keeping those lungs full, we'll say. So they don't empty, they don't collapse. Another, probably more important benefit is air remaining in the lungs allows for continuous gas exchange. So basically between breaths, when we're not breathing in extra oxygen, there's still air in the alveoli. So that air remaining, we can still undergo gas exchange. It's basically a reserve of tidal volume at rest that allows for this increase in tidal volume during maximal exercise by expanding into inspiratory and expiratory reserve volumes. So the benefit, we can still undergo gas exchange between breaths. Even when we're not inhaling more oxygen, there's still oxygen available. So let's discuss how frequency and depth of breathing kind of occur during exercise. So think about exercising and try to think back to what happens like kind of right when you start. So there'll be an increase in depth of breathing first at the onset of exercise. This is more energetically efficient. And think about it, increased depth of breathing. That's just like tidal volume. So we'll breathe deeper. We'll take in deep breaths. We'll activate all of our lungs, the top and the bottom. So more efficient. But now let's think about as we start increasing our intensity and maybe running a little bit faster, exercising harder, now we start breathing faster. So increased rate of breathing is secondary. So depth is first, rate is secondary, which is frequency. So what happens at high intensities here? So first, at light to moderate intensities, increased ventilation is due to increased tidal volume and increased frequency. But let's think about it. Let's think about at high intensities, what happens? Tidal volume plateaus. Why does tidal volume plateau? Because we can only reach a certain depth of our lungs. There's only so much we can breathe in or so much we can activate. Our lungs are only so big. But let's think about frequency. Breathing rate will actually becomes more important at higher intensities, and it's the only way to increase tidal or increase pulmonary ventilation. So recall, light to moderate intensity, we have an increase in both tidal volume and frequency to increased pulmonary ventilation. But with higher intensities, tidal volume will plateau off, and then frequency becomes more important and the only way to increase pulmonary ventilation. Also think about the muscles activated. So higher activation level of both the diaphragm and accessory muscles during these high intensity exercises. All right, let's move on to diffusion at the lungs. So this part here, I'd say, is pretty important. We're going to go over multiple different laws. All right, so pulmonary diffusion is basically how well the alveoli are delivering oxygen to and removing CO2 or carbon dioxide from the blood in the capillaries passing over them. And the pulmonary diffusion is described by 3 different laws. So we'll talk about Fick's, Henry's, and Dalton's laws. So first, let's just recall gas diffusion. So gas diffusion at the lungs or during capillary gas exchange is aided by 3 factors. So this is also a question. I think this is maybe the first question on your assignment, talking about gas diffusion and how gas diffusion is aided or what helps it. So first, large surface area alveoli. We already said a number. We know it's up into the 480 million range of alveoli. We also know there's a very thin respiratory membrane, and they're permeable. So they're only 2 cell walls thick. So 2 cell membranes thick. It's a very short diffusion area. So both membranes are permeable to O2 and CO2. Last is difference in pressures. So difference in partial pressures between the gases. And we'll kind of get into that, but we can look at it right here. So partial pressure difference between CO2 and O2. What is partial pressure? It's the portion of a pressure due to a particular gas mixture in a mixture of gases. So what this is, it's the pressure exerted by an individual gas in a mixture. And we'll get into Dalton's laws next, and that will explain that. But even with these 3 aids, there needs to be a driving force moving oxygen from the air in the alveoli into the blood, or CO2 from the blood into the alveolar air. So that driving force is the difference in pressure of the oxygen and the CO2 between the air in the alveoli and blood. So gas diffusion from an area of high pressure to an area of low pressure. And so we already see that here in this picture. We see that CO2 is going to move out of the blood into the alveoli, and oxygen moves out of the alveoli into the bloodstream. So yeah, let's... this video at the bottom, it shows gas exchange. It kind of just goes over this picture here, which I'll kind of keep explaining. But it's basically in the capillary wall, or the capillaries pass over the alveoli, carbon dioxide diffuses out of it into the air in the alveoli, and then oxygen diffuses out of this air into the bloodstream. And they each move according to their own pressure. And in this lecture, we'll describe what those pressure differences are. But first, let's get into Dalton's law. So what is Dalton's law? We can read total pressure of a gas mixture equals the sum of partial pressures of each gas. So this law was published in 1802, and it basically explains that each gas moves according to its own individual pressure. So the partial pressure of gas in a mixture is calculated by multiplying the total pressure of a gas by the percentage of each gas in a mixture. And so that's kind of what we see here. We're taking all the gases, we're adding them up, and we get our total gas. The fact that basically each gas moves to its own individual pressure kind of explains how each gas will move, acting kind of like it's the only gas in that container, even if there's more gases. Another way of flow is called bulk flow. So bulk flow is when all the gases in a mixture move together. So we see in this picture we have oxygen and nitrogen. Bulk flow would be if they all moved at the same rate, but they don't. These are different gases, and they each have their own pressure that they're going to move at. So a gas will expand to fill a container if it is in there without affecting the pressure of another gas. Basically, the molecules in a mixture are far enough apart that they act independently and they don't react with each other. So the pressure of an ideal gas is determined by its collision with the container. So that's how we know what the pressure of oxygen is in this container. It's how that pressure is or determined by its collision with the container. We have 159 millimeters of mercury. And then we look over here, we look at nitrogen. We see nitrogen has a pressure of 593 millimeters of mercury. And then when we add those two together, we see that increases based on their own individual pressure. So even though they're in the same container, they have their own pressure. So again, what's that pressure determined by? It's determined by the collision of the gas with the container. So that's how we determine the pressure. So again, the partial pressure of each gas is the pressure that the gas would exert if it was the only gas in a certain container. So that's basically Dalton's law. The gas moves according to its own pressure. And this will make more sense when we talk about atmospheric air and how it's made up of oxygen, nitrogen, and carbon dioxide, and they all have their own pressure. Let's move on to Fick's law. Fick's law talks about the volume of gas that diffuses is proportional to some different variables here. So Fick's law, you can kind of also write about Fick's law when you're explaining, I think it's number 1 on your assignment, where it talks about what benefits gas exchange, like why is, how can we have optimal gas exchange. These are kind of the factors that influence gas exchange. So diffusion, again, is the spreading of a gas more widely by the natural movement of their particles. So let's talk about each one of these. We've already discussed surface area. So diffusion across a membrane or a cell wall takes place according to a larger surface area. So if we have a greater surface area available, we're going to have more gas exchange. And that's basically due to the capillary beds surrounding each alveoli. We said that expands to about 70 meters squared, or about the size of a tennis court. So D, what is D? Diffusion coefficient. The ease at which gas flows. So that's what D equals. So ease at which gas flows, or diffusion. So it's the diffusion mobility. Another way to explain it is the magnitude of molar flux. Molar flux is the rate of mass flux per unit area. So this is basically just the magnitude of movement through a surface area per unit of concentration gradient out of a plane. So I know that's a very technical definition. All you need to know about the diffusion coefficient, it's the ease at which gas flows, or the mobility of a gas. T, thickness of a membrane. So we already said this is 2 cell walls thick. So with 2 cell walls thick, that's not a very large diffusion distance that the gases have to travel. And then last is partial pressures. So difference in partial pressure of gases. So difference in partial pressure of gases on an opposite side of a membrane. So we have one side a capillary wall, the other is the alveoli wall. The amount of oxygen diffusing through the membrane depends on the partial pressure difference between the opposite sides of those 2 membranes. So let's give an example. The partial pressure in the alveoli is going to be at 105 millimeters of mercury. The partial pressure in the blood is about 40 millimeters of mercury. So if you do the math, the driving force that's pushing those gases across the membrane is a pressure of 65 millimeters of mercury. We'll do more examples in a little bit, but that's just kind of one example of the difference in partial pressure. So again, just kind of summing up, if you look at this picture here, it explains each one of them. V, volume of gas, that's the total gas that's able to diffuse. What is that related to? If we have A, we're looking at the surface area. So total surface area we have times D, diffusion coefficient, how easily does that gas move? We have T, the thickness of the membrane, which we already know is very thin, and then P1 minus P2. So we would do this calculation for both oxygen and CO2. So we have CO2, we would take the pressure on the outside versus the pressure on the inside. We would do the same thing for oxygen, pressure on the inside versus pressure on the outside. And we would calculate that, and that would get us how much gas did actually diffused. Last law is Henry's law. So Henry's law, amount of gas dissolved in a fluid depends on what? So what is this referring to? It's the amount of oxygen and carbon dioxide dissolved in blood. Blood is the fluid. So this was published shortly after, who was it? Dalton's law in 1803. So first, let's talk about, or we have each one of these. We have temperature, solubility, and partial pressure of gas. The only term we probably need to define is solubility. It's the ability of a solute to dissolve into a solvent. So the ability of a gas to dissolve in a fluid. So it's the ability. So that's all solubility means. All right, so we want to understand each one of them. What happens to temperature of our blood? It actually remains relatively constant at rest. So throughout the day, the temperature of our blood does not change that much. It slightly elevates with exercise, stress, and then when we're sick. Solubility of gas, this is also relatively constant. So how easily does oxygen and CO2 dissolve? Relatively the same. It stays the same throughout the day, except with exercise, we have increase. So there's an increase in the ability of oxygen and CO2 to dissolve. So if both of those stay relatively stable and constant, then that means that the amount of gas dissolved in blood is going to be directly related to the partial pressure, because temperature and solubility doesn't change very much. Partial pressure does. So higher partial pressures are going to allow for a greater amount of gas that will be able to dissolve. Again, with the higher pressure or the greater difference in pressure, that equals greater gas diffusion and the ability of gas to dissolve in a fluid. So that's basically Henry's law, pretty simple. It just talks about how easily does oxygen and CO2 dissolve in blood. Just note that temperature of the blood and solubility of the gases are relatively stable. Partial pressure of the gas will change during exercise. So it changes during exercises and it's going to increase, and that's what's going to increase the amount of oxygen that dissolves in the fluid. All right, so let's do a quick review slide before we move on to the next part. So again, we have our definition of partial pressure. So the portion of pressure due to a certain gas in a mixture. Another way to explain it, pressure exerted by an individual gas. Atmospheric pressure, also called barometric pressure. This is the weight of the air at sea level is, what is it? 760 millimeters of mercury. Next, we're going to learn about how does the partial pressure of oxygen and CO2 change as they travel throughout the body. So we're going to start with the air, we're going to start with the atmosphere, and then we're going to move to the alveoli in the lungs, and then we're going to move to the blood surrounding the capillaries, and then we're going to move to that blood delivered to the tissues. In each one of those locations, there has to be a driving force. What is the driving force? It just allows the gases to diffuse across the membrane. Remember, all gases move from high areas of pressure to lower areas of pressure, and they're all going to move according to their individual pressure that they exert. Okay, so let's move on to oxygen diffusion, or the cycle of oxygenation. Okay, so oxygen diffusion into the blood depends on this top statement right here. So the partial pressure, that's what PO2 is. Partial pressure of oxygen must be greater in the alveoli than in the blood, and greater in the blood than it is in the tissue. So let's start at the atmosphere. So let's start at the partial pressure in the atmosphere. So we have 159.1 millimeters of mercury. Remember, we said that total atmospheric pressure is 760 millimeters of mercury, but atmospheric air is made up of 3 gases. It's made up of oxygen, nitrogen, and carbon dioxide. So we're just talking about oxygen on this slide here. So we have this pressure, 159.1. That's going to decrease from sea level to within the alveoli, and we see that here. Why is that? Due to the mixing of air, or due to the mixing of atmospheric air with a high PO2 and the air left in the lungs after exhalation, which has a lower percent of oxygen. It has about 14.5% compared to 20.9% in atmospheric air. Why is this? It's because oxygen is diffusing from the air within the alveoli into the blood, so the pressure of oxygen in that area is lower. All right, so sea level to the alveoli. Another reason why we see a decrease here is the humidifying of the air in the lungs. It adds water vapor, and if it adds water vapor, there's an increased percent of water, and now that partial pressure is different. So this is according to Dalton's law. So according to Dalton's law, the partial pressure of other gases in a mixture must decrease, resulting in a PO2 in the alveoli dropping to 105 millimeters of mercury. So we have sea level, we inhale, so we take a deep breath, and now we get that oxygen into the alveoli. The pressure decreases. Again, the mixing of the air with the water as it's humidified. And then also we said due to that lower pressure of oxygen already in the alveoli. Now we want to look at the alveoli, and then we want to look at the partial pressure of the blood entering the lungs. So this blood here is deoxygenated. So this deoxygenated blood is going to have a lower partial pressure of oxygen. So think about the alveoli, and then think about there's capillaries surrounding that alveoli, and there's blood entering into the lungs. It just came back from the heart, which just came back from the body. It's deoxygenated, so it has that lower partial pressure. So this is the driving force. So there's a difference here from 105 to 40. What's that difference? It's 65. So 65, and that's in pressure, 65 millimeters of mercury. That's the pressure that oxygen is going to use as a driving force to move across the membrane. It's going to move from the alveoli into that bloodstream. All right, now the blood is leaving the lungs. Now this blood is oxygenated. So now our partial pressure has increased. So the partial pressure of oxygen is higher because now there's more oxygen there. So now this blood is leaving the lungs. It's going back to the heart, which will then pass through the body and it will be delivered to the tissues. Now let's look at the partial pressure in the tissues. So this is the partial pressure of oxygen, let's say in a muscle. So let's say in that muscle, the oxygen level is lower. This allows for the blood passing into that muscle to deliver all of its oxygen. So now we have another driving force. If we do the math, 40 minus 10, now we have 60. So again, this is pressure. So 60 millimeters of mercury is the pressure that is exerted to push and act like a driving force to push the oxygen from the blood entering a capillary into the actual muscle. So it diffuses from the bloodstream into the muscle tissue. So sum it up, the differences between the PO2 and the alveoli in the blood we said was 65, and the difference between the blood and the tissues is 60. This is the driving force. It's the pressure pushing oxygen into either the bloodstream or pushing oxygen into the muscle tissue. So this picture here will show all of that. So we have our PO2 at sea level, which we said total atmospheric pressure is 760, but the partial pressure of the oxygen is 159.1. So as that enters into the alveoli, it drops to 105 millimeters of mercury. We said this is due to the increased water vapor decreasing that partial pressure. So don't worry about the PCO2. We'll talk about that on the next slide. So just look at the PO2. So this is our lung. We see our lung here. We see our alveoli structures. This here is the capillary. So now we have oxygen. We see it. We follow. It's diffusing into the bloodstream. So this is to the pulmonary vein. So this now becomes oxygenated blood traveling back. So we see it, the PO2 then increases to our 100. And where did that increase? So we see PO2 here from the pulmonary artery. This is deoxygenated blood coming from the right atrium. And then we see it changes now, PO2 of 100. So now this travels back to the left atrium and into the ventricle, which will then be passed back to the body. And so that's what we see here. So in the systemic arteries, so the periphery, partial pressure of oxygen is 100. And then as it passes through the muscle, we see oxygen will diffuse into that muscle. So now what happens? That's going to drop the PO2 back to 40, and that's what's going to enter. We already said here that the PO2 in the muscles, we said that was 40 millimeters of mercury. So the driving force in the tissue we said was 60. So this is one cycle that you'll need to kind of understand. Is just how partial pressure changes. And I think this is the last question on your assignment. So you can use this last slide here to talk about how partial pressure of oxygen changes as it passes through the body, and looking at this picture here too. Now let's look at partial pressure of carbon dioxide. So at sea level, it's very low. So there's not a lot of carbon dioxide in our atmospheric air. So we see 0.2. Now let's look at in the alveoli. But now remember, we're going the opposite direction. In the partial pressure of carbon dioxide in the arterial blood entering the lungs is going to be 46 millimeters of mercury. But now look, we're going the opposite direction because we have to get rid of the carbon dioxide. Think about this arterial blood. This arterial blood just came, basically, it came from the heart. Think with exercise, the muscles are producing CO2. If muscles are producing CO2, it's entering back into the bloodstream, which travels back to the heart and then eventually travels to the lungs. So that blood is carrying more CO2. So the driving force here is only 6 because we take 46 and we subtract 40. So what are we talking about again? We're looking at the blood in the capillaries surrounding the alveoli, and here's the alveoli. This is the pressure difference, 46 to 40. We have to get the CO2 out of the blood and into the alveoli. If we do that, we can exhale and we can get rid of the CO2. So the pressure pushing that CO2 is very small. It's only 6. Now let's look here. How did that pressure get, or how did that CO2 get from the tissues, from the muscle, into the bloodstream? So we have to have another driving force. So here I want you to think about the muscle. Think about we're exercising, and all of our muscle tissues are producing CO2. So there's going to be a high partial pressure of CO2 in the muscle and a lower pressure of CO2 in that blood leaving the lungs. So we look here again, we see partial pressure is 6 millimeters of mercury. That's the driving force. So here's our summary statement. The difference between PO2 in the alveoli and the blood is 6, and the difference between the blood and the tissue is also 6 millimeters of mercury, providing that driving force for diffusion of carbon dioxide. So just to kind of summary here, this arterial blood is blood returning from the body's tissues entering the lungs. That driving force is 6 millimeters of mercury. So carbon dioxide in the arterial blood is trying to get into the alveoli to be exhaled out. And then we look here, blood leaving the lungs. This is blood traveling back to the heart to be delivered to the body. So it's going to the body. It's low in CO2 at this point, but as that blood enters into the tissues, now the tissues are going to pass off the carbon dioxide. So CO2 moves from the high area of pressure to the lower area of pressure. So 6 millimeter mercury driving force moves that CO2 into the tissues, or in the tissues, into the blood to be delivered back to the heart, eventually to the lungs, so we can exhale it. There's less of a driving force for CO2 compared to oxygen because the membranes are much more permeable to carbon dioxide than they are to oxygen. So a 6 millimeter mercury driving force for CO2 compared to the 65 millimeter of mercury pressure for oxygen. This video down here at the bottom also explains everything I just said, so you can watch that video on your own time. The video again just explains the cycle of oxygenation and the driving force that has to be present for diffusion. Last picture that explains this is, again, we're looking at our atmospheric air. We look at oxygen and partial pressure, or sorry, oxygen and CO2. We now inhale, it's in the alveoli. We see here that it drops. We have 105 and 40. So oxygen passes into the capillary, CO2 will diffuse in the opposite direction. If you follow here, we have pulmonary vein back to the heart, to the left atrium and ventricle. We see those numbers have changed slightly as we move, and then now we get into the body's tissues. We'll say this is a muscle, and then oxygen will move into the tissue, CO2 will move out of the tissue. So you notice how CO2, or partial pressure of O2 and CO2, changes as it moves throughout the body. Just remember, partial pressure of CO2 is high in the muscle because the muscle is exercising and producing CO2 as a waste product of aerobic metabolism. Also note that partial pressure of oxygen is low at the muscle because the muscle is using oxygen, decreasing the total amount or the total pressure exerted by that gas. All right, so now what we would do would be a critical thinking. So y'all would all do this as a class. So I'll kind of put everything up, and I do want you to try to answer these questions. So what you would do is pause this video and try to answer all of these questions. These will be on the next exam, but I'm about to go over them on the next slide, so pay attention. But let's look here at the top. So what I'm asking you to do is partial pressure of gas mixture. How do you figure that out? Calculate by multiplying the total pressure of each gas, which I have given you, by the total pressure that we see here. So at sea level, we know 760 millimeters mercury. What is that composed of? Mostly nitrogen, then O2, and then CO2. So they compose each of those percentages. So I'm asking you to calculate the pressure of each gas. What happens to the percentage of oxygen as we go into higher elevations? Like let's say we go to Colorado. What happens to the percentage? Also, what happens to the pressure at higher elevations? Let's say Colorado. Why is it harder to breathe the higher we go in altitude? And then why do athletes train in high altitudes, and how high is necessary? So here we go. All right, so calculate each pressure. So this is kind of the first thing I would have y'all do is you take 760, so the total gas or the total pressure, and you multiply it by the individual pressure exerted in a percentage form. And so that gives you 600.7 millimeters mercury for nitrogen. You would do the same thing for oxygen and CO2. But we already know the oxygen and CO2 numbers because we looked at them in the examples on the last few slides. Next question is what happens to each percentage as we go into higher elevations? So the answer of this, the percentages stay the same. The total percent stays the same, but what's going to happen to the total pressure? Total pressure will decrease. So atmospheric pressure or barometric pressure will decrease as we go higher. Why does it decrease? The atmosphere is basically less dense, so the air molecules are further apart. The lower pressure makes it more difficult for oxygen to enter the vascular system. So that's the next question. Why is it harder to breathe at higher altitudes? Basically, the air is less dense. So pressure plays a role in the ability of the body to extract oxygen from the air. So if there's less pressure, there's less of a driving force. And if there's less of a driving force, getting oxygen into our alveoli or into our bloodstream, then it's going to be harder for us to exercise and move and feel like it's harder to breathe because we can't extract that oxygen from the air. So the lower partial pressure reduces the effectiveness of the gas transport. So gas transport is less effective as we move into higher elevations. But why do athletes train in high altitudes? So why is this kind of a beneficial training, let's say, regimen for an athlete? Basically because it allows our body to undergo adaptations. So it triggers hormones that produce red blood cells. We kind of already talked about this, actually. We talked about this in chapter 6. We talked about EPO, erythropoietin. So that's a hormone produced by the kidneys that stimulates red blood cell formation in the bone marrow of our long bones. So EPO, when that increases, that aids in oxygen delivery. So if we have more red blood cells, we can carry more oxygen, meaning we can carry more oxygen to our muscles, meaning we can exercise for longer. And next is how high is necessary. So I would normally ask, where is the Olympic Training Center located? It's located in Colorado Springs. How high is that? I think it's just right around 6,000 feet. I think around 5,000 is when humans start to undergo some adaptations, but by 6,000 and higher is when you'll start to see the greatest benefit of those changes. Like I said, you'll have an exam question over this critical thinking question that we did here. So you can pause this slide and write down everything if you did not get to in time. But that's all we have for this. Oh, there's that part there. That's all we have for this part of part 2. So we're done with part 2. And the next video